All right. I think we'll get started. Hi, everybody. My name is Steven Famularo. I'm from the Children's Hospital of Philadelphia. I've been there for a little over 5 years now as a coordinator, and then moved on to a project and program manager. And I'm one of the chairs for the research network for PALISI. Today, we're going to be talking about co-enrolling or multi-study consents. And how to navigate some of those approaches and kind of dive into what some sites do, what some sites don't do. I want this to be sort of like a discussion, a conversation. I'm going to be going over some things that we have presented in the past. So as I'm going through, I'm going to be using these slides to kind of help me navigate this this topic. But if you have any comments, questions, or insights that you are doing at your own site, please feel free to share. You can interrupt at any point throughout, okay? So let's begin. So first off, I'd like to thank Ryan, Josie, and Mason for their input in creating these slides. A lot of this was done by Josie a couple years ago when we first gave this talk. And then I got some recent input from Ryan and Mason as well. And then just to give a disclaimer for today, this discussion is not meant as like a how-to guide to tell you exactly how you should go and approach and consent certain patients, or how to operate or direct your teams at your sites. This is just to use as a resource when you're navigating some of these situations. Okay, so some of the key objectives that we're going to be going over are the ethical considerations of approaching or not approaching patients or families for multiple studies, selection bias, impact of picking and choosing which studies to approach for if a subject is eligible for several studies, and say you only pick 2 of 5 to go and talk to them about. And then going over some of the challenges and considerations for each of these approaches. And then some of the strategies that teams implement. As far as like ethical considerations go, we don't want to be like, one of the perspectives is you don't want to be denying parents the opportunity to participate in studies they might want to otherwise participate in if we're only approaching for one or not all of the studies. And then a question to consider is, does your team or does your institution, do they actively enroll subjects in multiple research studies? Or do you selectively choose which studies to approach for if they're eligible for more than one? So being that we are a network under PALISI, or a group under PALISI, a lot of our studies are based around sepsis, MODS, ARDS, and so a lot of our studies will overlap with the patient population that we are screening for and identifying eligible patients. So because of this has become a topic of growing interest with how to approach these situations where we're doing multi-study consents and co-enrolling in different areas. One of the big things is that if you aren't there yet, you want to try and improve your comfort level and success in co-enrolling patients in multiple studies, as this allows for maximum research benefit as we seek to learn about all of the different types of diseases and conditions that we're managing these projects for. And then despite concerns about overburdening families, there is some research that has shown that in general, families are supportive of co-enrolling in studies. And it may give them this one piece of meaning that is like giving them some comfort out of this difficult time that they're spending in the hospital, overseeing their child in like one of their worst conditions that they may be in. So going over the selection bias. So bias is introduced by selecting subjects for study inclusion based on their characteristics instead of a randomized fashion. By introducing selection bias, the enrolled patients are not fully representative of the population being studied. So as an example, we have a child, his name's Anthony, he's eligible for 3 studies. 2 are unfunded, while 1 study is funded. When the research team approaches the family, they focus on the funded study and present the unfunded studies only if the parents are agreeable to the first one. This is one approach that may have been taken in the past or at present day with certain institutions or teams within those institutions. To go on, some suggestions that address the selection bias is to maximize the number of studies we co-enroll for, make decisions based on factors other than patient characteristics, and if using a first approach or priority strategy, make decisions based on randomization or by regularly rotating which study gets priority approach. Additional considerations for interventional trials or randomized control trials, engage the interventional trial PI on safety and scientific integrity of co-enrollment, and ensure that the study in question will not be ultimately blinded by data elements from another trial that are needed for analysis. So for some general challenges, logistical issues, if the patient has blood drawing access, how much do they have? Is it an arterial line, a central line, PIV that may be like a little bit finicky and cannot get the amount of blood that you are trying to obtain? What the blood volume limits are, and the severity of illness. So I would say a lot of these play key factors into whether or not you will actually approach a patient for 1 to multiple studies. Another big challenge is the funding priorities. So your team or your PIs or however your research team is structured, the PIs may need to prioritize studies offering payment in order to supplement the investigator-initiated studies. So at some sites, the funding for 1 study might be plenty to cover maybe for that one plus another one if they're co-enrolling in the same patient population, and there is an added burden on the research group to actually maintain that study. Approach challenges. So from the research coordinator or assistant side of the house, the coordinator comfort with these approaches. So the ability to read the room, that's taking into account if it's only mom or it's only dad that you're talking to, or if nurses are in the room and you haven't spoken to them about the number of studies or the quantity of blood or the other study procedures that you might be taking, how they may be reacting to the situation. If parents have family there, whether they're aunts, uncles of the patient, or if they are like grandparents who might have some influence over the parents. And so you want to make sure that you are talking to everybody, but knowing who your audience is and how to navigate the situation depending on who is all there. And the familiarity and comfort with ICU scenarios. So there's a lot of stuff that's going on in the ICU, and sometimes you might be in the room while the team is actually conducting a procedure, and it might just be due to the timeline of the enrollment window for the study. I know that there's been times where I've been in the room and the team is actively transitioning the patient from one ventilator to another. So you got all these loud bells and whistles that are going off. You got maybe 2 full teams in there, and so the room can be crowded. But the family might be comfortable in that situation because their son or daughter might be like frequent visitors to the ICU, and so they know what all this is, and that might be a perfectly okay situation for them to actually talk to you. Other families might be the first time that they're introduced to anything like that. And so they might just tell you, like, don't even talk to me right now. Or they might be okay with discussing research, but might want to leave the room and go to somewhere where it's a little bit more quiet. And then your experience with multi-study consents. So there's different levels of experience, and then there's different levels of multi-study consents. So you could have 2 or 3 studies that you're going for, or you could also have 10 to 15 plus studies that you're going for. And it all depends on if they're eligible, how the PI wants to handle some of the situations, and then also the clinical team as well. There are some psychosocial challenges, so the family's readiness, which I kind of touched base on, their ability to remain attentive. So for some of our trials where they might have shorter windows to go and approach, the parents might have been awake for greater than 24, 36, maybe even 48 hours because of everything that they've been going through. And so they might be sleep deprived, or maybe they're staying in the room with their son or their daughter, and so they're waking up every single time the nurse is going into the room, and they're getting inconsistent sleep. Or maybe they're just overwhelmed by the whole scenario that's going on. You need to be able to read these cues and gauge their attentiveness when you're having these discussions with them, because it might not be the best time. The risk-benefit assessment of approaching the family for these studies, the general attitude towards research, and then perceived integrity of the consent process. You might be going for several studies like I mentioned. However, that does not mean that you should compromise the integrity of the consent process. You should always be going over every single section that you need to make sure that the family is aware of everything that's going on. And then also all the sections that are legally required to be discussed with the family. Like, you should not be skipping out on anything when discussing the studies with the parents, if they're willing to hear about the research in the first place. Is there any comments, questions, or concerns about like any of this that anyone has run into, or other challenges that maybe you have faced that I haven't mentioned? Okay, I'll take that as a no and keep moving forward. All right, so now we're heading into strategies for approach. So you want to work with your PI, or if it's if you have like a team of PIs, you want to work with them on defining a priority for like a first approach plan. So in this, you want to consider developing a priority plan on rotating or randomizing the basis rather than selecting a certain specific study based on like the patient-specific factors. With the priority or first approach, this study is mentioned first during that approach. The only study approach for depending on perceived ability of the family to handle the co-enrollment. And it's the only study approach for depending on families' willingness to engage in research discussion. An alternative to that is to commit to approaching the families for all eligible studies. I know this is something that's done at a handful of institutions. I'm not sure about others. It's something that we try to do all the time here at CHOP. And with this approach, we try to do it to where it's only one approach, where we're not going several times throughout the day or over consecutive days where we're talking to the family about several different studies where it could have been potentially bundled all into one. I'll go a little bit more in depth with that as we progress through some of these slides. Priority strategies. So at each co-enrollment approach, use a randomizer. So this could be something as simple as like a something that you find on Google as sort of like a coin flip based thing where you're able to randomize which study you go and approach for. You can rotate on a monthly basis. So like 1 month, it might be sepsis focused, another month it might be ARDS, another month it might be just plain mods, no matter how they have mods, however you have it prioritized. And then again, some sites or some approaches might be prioritized based out of necessity for funding versus unfunded studies. So we're going to go through some of the examples. So the all-in approach. So this is something that we do here. So in the morning, we will identify who's eligible for our studies throughout the day. And once we identify and confirm the eligibility, we'll go through and start looking at all the study procedures, see what procedures can be combined, or if it comes to blood drawing and all the studies are blood drawing, see what the amount is that we need to collect. And then all of this then gets filtered to the clinical attending for that patient. We'll tell them about how many studies we plan on approaching for, what kind of studies they are, so generally if they're sepsis, ARDS, and so on and so forth. What the study procedures are, so like if they need imaging, if they need blood drawn, if it's precise, which is one of the interventional trials that we have going on here, and I think a lot of you are participating in it. So if they're getting drug or potential placebo, if there's others like prospects, if they're going to be randomized to where they have protocolized ventilation management or going on to a different ventilator or a different positioning. We talked to the clinical attending about all this. In the past, we used to go in person to go and talk to them about this. And because our studies are time sensitive, we would kind of break up some of their rounding. So like when they went from one patient to the next, we would try to meet them while they aren't actually just actively discussing a patient to brief them on who we plan on approaching and why, and what we need their approval for. These days with Epic advancing and evolving, they are more comfortable with us Epic chatting them. And so we're able to put all this into one chat. They can see all of our questions that we have, all the study procedures, and they can approve or decline our approach, whether it's for all or partial of the studies. If they end up declining any of our studies, we do have a SOP in place to where the study PI will then reach out to the clinical team to get a little bit further information on why that decline was made. Following that, we'll then go to the bedside to talk to the nurse, or we'll Epic chat them to make sure that they're aware that we plan on approaching the patient's family for these studies. And then I'll typically always give them a heads up, like, hey, if mom or if dad or if parents or if legal guardians, if they consent to these number of studies, then today we're going to need to collect this amount of blood. There's going to be a couple of echoes that are done and so on and so forth. That way, if there's anything that we need to plan around, so if the patient's going for a procedure somewhere, or if the team is going to be coming to the bedside to do something, or if they're bathing or whatever it may be, we can work around that. And the nurse is a little bit more comfortable because we're telling her or him all this information up front. So when the parents do say yes, then we have seen that we have gotten less pushback, especially when we go for 6, 7, 8+ studies. And we're getting what seems to be a lot of blood from the patient in one day at one time. We'll go through and we'll print the recently approved consent forms and any other ancillary documents needed for the approach. That way we're always using the most up-to-date and not using any out-of-date consents. With the approach itself, we will, once we approach the family, we'll always introduce ourselves. Pretty much every single time we go into the room, we'll introduce ourselves, even if we were the same person who consented them, just because they're going through a lot and they might not remember your face and your name. When we go to talk to them, we'll kind of explain the role of research and kind of where we come into play. And I don't know about all the institutions that are represented here on this call, but here at CHOP, research is one of our like 3 main goals as an organization-wide goal. So that's sort of where we bring it in. The first 2, we say that it's clinical care, and then the second is education. And so as we're doing this introduction and we actually involve parents in like the process of like how we're coming into play with research here, maybe at first they were completely closed off to research, but once we kind of give this little intro, they might be a little bit more willing and ready and attentive to hear what we actually have to say instead of just shutting us off altogether. And even if they end up saying no after the fact, we tend to get a little bit more information as to why they say no, and we can kind of tailor our approaches, our future approaches based off the feedback that we gain from them. We'll then go into a brief overview of our studies, and we kind of group them together based off of disease type or procedure type. And the 2 big things here, especially with this research network, is sepsis and ARDS. And I would say as far as how we determine which studies are discussed first or discussed last, I don't really think there's any sort of like randomization to it or anything. It's sort of, if we're going for a trial, since the trial has benefit, that is one thing that we will present first. Or if it's something where the trial might have an extended window of consenting, we might tell them about it just so that they are aware of it, and let them know that if things continue along the way that they are, that we would come back later that day or maybe the next day or 2 days from then to actually consent them for the study. But we just give them like a brief overview so that they at least know. And we'll typically always follow up with them if we do talk to them that one day, but we don't actually consent them for that trial. We'll come back and say like, hey, like Anthony or Sally or whoever their son or daughter may be, like they've actually improved or they've gotten to the point where they no longer meet study criteria. So even though I did discuss that trial with you the other day, they're no longer eligible. And then we'll go into our observational studies, which are a bulk of the studies that we do consent for. And since they're observational, most if not all are less than minimal risk. Most of the time, if the parents are inclined towards research, we see that they will consent to all the studies that we approach for. I think some of the highest number of consents that we've approached and consented are in the teens. I think it was like 13 or 14. And if they didn't consent to all of them, then it might have been like 11 or 12. And then they would give us reasonings for why they said no to the others. Once we get like a general gauge of how the parents are regarding, or the legal guardians regarding the studies that we're approaching for, I'll generally get like a indication from them somehow saying like, is this something that you're interested in? Do you want us to proceed further with these consents? And I'm always like giving them opportunities to ask questions along the way because I know it's a lot. And for some of the studies, especially the more complex ones, I'll repeat certain things. That way they know, again, because they're going through a difficult time and they might be short on sleep. So I want to make sure that they know everything. And as then when we're going through each of the studies, I'll break it down consent by consent, review the things that I've already said to them. And then I'll go into detail on the specific things regarding each of the studies. That way they know that we're discussing everything within the consent forms and we're not leaving anything out. I'm very upfront with them about it. So in the beginning, if we are approaching for 10 studies, I'll say, hey, like we are going to be talking about 10 studies today. You can say yes to all of them. You can say no to all of them. You can say yes to some and no to some. And that doesn't like impact any of their clinical care. This is just something that is optional and that we give the opportunity to everyone who may be eligible to participate. So once they know up front, however many studies that you're going over, it kind of provides that space or that leeway when you are going through the consent forms, because there's a lot of pages that you have to go through and a lot of signatures if you are going for that many studies. And it's twice the amount if they don't speak English and you have an interpreter and you're using translated consent forms or short forms to double document the process, essentially. Is there any questions or comments or anything that anyone else has kind of like done something similar here? Or maybe you have a little bit of a twist towards this approach? All right. Another way to do this is the most invasive first approach. So some of the prep work for this, again, reviewing total blood volume needed for all the studies combined. If the volume exceeds the limit, review which studies, if any of the studies have the ability to reduce the amount of blood that they are collecting in order for that study and that subject to still be evaluable. Initiate any communication necessary with the RN, the clinical team, the PI, whoever it may be that needs to be involved. And then again, printing all the most recently approved stamped consent forms and anything else that may be needed during the approach. Again, introducing yourself and explaining the role of research. Again, going over overview of the most invasive study or the one that requires the largest amount of blood draws or the largest amount of blood. And then continue on past that towards the other studies. And again, you want to keep the integrity of the consent process. So you're reviewing in detail all those consent forms with the parents. Some other tips. If applicable, highlights if families the minimal risk status, despite the enrollment in the multiple studies. Use volume reduction strategies, as I mentioned. Timing and anticipation is everything. Hold off on an approach to achieve a single approach and eliminate the staggering. So it does impact consent willingness or even the willingness to hear about research if you are staggering the approaches. It has been seen here throughout the past, maybe when PIs were working with different groups, or maybe they weren't all on the same page, and so one family might have been approached several times in one day, and by like the second or third time, they're like, why are you coming to talk to us? Like, we already said yes to research, or we already said no to research. Or if there's other teams throughout your institution or throughout your hospital that you weren't aware of that were enrolling patient populations that are in the PICU. And so you might be going for your first approach, but they were already approached for research. So one thing when it comes to this is we have started like reaching out to all those external teams that are outside of the ICU research team. And so any sort of research that then goes through the PICU, they're now coming through us. And we have a general rule of thumb that whenever we are approaching, at the end of the approach, whether the parent said yes or if they said no, we ask if it's okay if their son or daughter, if they become eligible for more studies in the future, if it's okay that we continue to approach them. Once we get that information, we'll then pass that along if there's an external team that wants to approach. That way they know what they're walking into if the parents are okay to approaching, or if they know that they shouldn't approach because the parents kindly asked to not be approached for any research during this hospital stay. So those are some things that we've encountered. And it's also good to know that way, like say you're screening in the morning, but then it comes time by the afternoon or maybe the next day you didn't realize it, but they might be eligible for another study within your own team. that way you already know, like, you've built up that rapport, you already got the permission to where like they're like open to hearing about more research, so it's not as difficult of an approach if it is a second or a third approach for research studies during that admission. Again, yeah, so this kind of goes into that a little bit. So do not delay approach if the window for eligibility will or may close, but just let them know that they may be eligible for more studies. And there's some research out there that has shown that co-enrollments are agreeable to the patients and parents without causing further them to be like further burdened or overwhelmed by the whole process. You want to know your limits. So you want to understand local total volume limits when it comes to blood drawing and maintaining that minimal risk status. Knowing the NIH sponsored studies, so a max of 5 mLs per kilogram per day of blood when it comes for research, and then a max of 9.5 milliliters per kilogram over 8 weeks for all studies. And you don't want to lose track of the volumes that are collected regarding clinical labs that are drawn for research purposes. So you want to make sure you include those as well. And then if your local IRB has any guidance or limits on co-enrollments. So, anyone here that's on the call, is there anything that's that your local institution or your IRB where they restrict co-enrolling, or if there's like a certain limit to the amount of studies that you can co-enroll in?
Hey, Stephen, it's Lisa at Nationwide. Just commenting on the fact, other teams coming into the intensive care unit. We've also kind of gotten familiar with some of the other studies that might be approaching, because maybe there is a potential for benefit. And while we got to the patient first, we would say to the families, there is another study team that's going to come talk to you, even if they said no to us, to say, let them know this study that they're going to talk to you about has the potential to help your child. Are you okay with them coming and reaching out? And then we've also asked the other teams themselves that anytime they approach a family in the intensive care unit, to let the family know there is a chance you could become eligible for other things, just as kind of like their spiel and stuff. We, at least that are familiar with the other teams that are coming into the intensive care unit, and know what is out there, because have been a few studies that everyone's interested in the flu, but because they can enroll on the floors, we've asked their teams to give us first crack at the flu patients in the intensive care unit, because we're only enrolling in the intensive care unit, and they have the opportunity to enroll on the floor. And we've just kind of gotten together with the other teams and come up with ways to make it work for all of us. We've also done some co-enrollments where we've gone in the room together and done it all at one time, so that way then the family parts of the consent forms we can kind of summarize. This is what Lisa was talking about when she was talking about the HIPAA language and de-identifying samples, the summary parts, so that they're not having to hear it 15 times. And I just want to say, you guys doing 15 consents at once, you rock. I can't even imagine the amount of paperwork that takes to get it all together. So but that's just how we've learned to deal with other teams here at Nationwide, because we also probably have a lot of teams coming into the intensive care unit, and would rather save the families if we can also.
Yeah, that's a great point to bring up. And we've encountered some of those situations as well, where it might, like, have asked some of those teams to hold off on enrollment until the floor. And then some of them don't have such like a strict time frame to enroll. And so maybe they don't need to go in that first 24, the first 48 hours to go and consent the family. But maybe they can wait until it's closer till they're discharged. And so there's other situations like how you said you've like gone and approached together. there might be research studies that are done in your EDs where the families are either approached or maybe they have an exception to informed consent for some of those studies, given the critical nature of them within the ED. But they may be approaching later when the patients are transferred from there to the PICU. So in those situations, given that some of the studies might offer benefit, we have informed those teams to make sure that they're reaching out to us. That way, if it is okay if we approach first, or if they would prefer that we approach together, that way we can kind of coordinate how that works. But thank you for bringing that up, Lisa. That was very important. And then with that, so like with the multiple studies that you might be going for, so say one person on your team is very strong and manages a lot of the sepsis studies, and then another person on your team is very strong with maybe the flu studies or ARDS studies. You don't have to handle this approach if there are multiple studies by yourself. You can always go into the room with another person. Sometimes it might be 2 more people, but you need to know how to, like, if the room that you're going to is smaller than some of the other beds that are within your ICU, or if it's larger, it might be able to handle 3 people from the research team and not seem closed or not seem like congested or intimidating. That way, the whole burden is not on you to keep track of every single study procedure for all the studies. If you're not as familiar as someone else on your team, you can always handle that together and do like a tag team approach. These were some of the references for some of the studies that have shown that co-enrollment has not produced a greater burden when you do have several studies that you are going for. This is where you can reach us at, PALISIcoordinators@outlook.com. Here's the website, PALISIcoordinators.weebly.com. This is like a screenshot of what the homepage looks like. You got access to like the directory. We post our recorded webinars such as this through that link. The mentorship program, and then we typically give information on any sort of upcoming events. So coming up in June, we have a feasibility and study intake. July, we have PICU consenting, part 1 of 3 training, and then in August, a part 2 of 3. As a plug for the upcoming fall PALISI conference, we'll be doing the SOCRA CCRP exam. So please log on to the SOCRA website to register if you're going to be attending the conference. Again, here's the information for that. So September 4th through the 7th for the PALISI conference in Minneapolis, Minnesota. And we're going to be doing like a education day. So if you have any topics or if you want to become a presenter, maybe in the fall or the next spring, you can scan this QR code to suggest some of those topics or volunteer. Josie, have there been any comments or questions or anything in the chat?
Nope.
Okay. Here's a little bit more of a breakdown of that day for fall PALISI. And then here's our current team. That's all I had for today. So I'm going to leave the floor open to anyone who wants to share some of their experiences with co-enrollment or has any questions for either myself or any of the other people that are on this call. Yes, Amy.
Hey guys, good job, Stephen.
Thank you, Amy.
I may have mentioned it to this group before, and this is not from my current role with Martha, but in my previous role in neuropsychiatry here at Penn, which is was a large lab in the school of medicine. What we did for co-enrollment was we established what we called a common protocol. because most of the studies that our faculty were running had some basic elements, things like a blood draw. We did MRIs pretty frequently. So anyway, we looked at sort of the common elements across all the protocols, hence the name common. And we drafted this protocol for approval with the IRB. And the way that we utilized that was any patient who came in onto the unit, whether it was for inpatient or outpatient, was approached for research. And if they were interested in research and in these, at least these basic elements, then they were consented using our common protocol. And then at that point, and we had a very small team. So at the time we first started, there were about 18, 19 coordinators across 13 faculty. So this way, and we had a controlled environment of who was approaching patients. So I had a rotation of, you were kind of like on call, right? And so only certain people were approaching patients during that time frame. And they were approaching them, and everybody was trained on this common protocol. And then that was a way to kind of engage the families and not overwhelm them, but also at least welcome them to research. And at that point, once they were sort of enrolled in the common protocol and they went through these basic procedures, at that point, other coordinators, and we would come up with a rotation and a process, could approach them if there were other additional activities for their particular study. If they needed an EEG or if they were doing something else, maybe it was a med trial, whatever it was. And that was kind of a way for us to control it. It may not be applicable if you're a smaller unit. For some of the larger units, it may be helpful. And then the other aspect that came along was when the broad consent was approved. What we ended up doing was slicing that out of the common protocol. So then we had a broad consent just for blood. And those were the two consent forms that were signed for anyone who approached, who came to the unit and was interested. So that was just kind of how we handled co-enrollment. It made things a little less chaotic and less people getting approached and saying, like, I just agreed to do an MRI. Do I really have to do another one? And sometimes patients were, for years, they were doing like, we were sticking kids in scanners like 6-7 times in a week, So anyway, that was just kind of an approach we took. It was a larger unit, so it made sense. And then what happened was the faculty then had to agree. So the other investigators had to agree to that process, right? Because they then knew that for their protocol, they may end up getting like 5 out of 6 activities done, whatever it is. Because the person has said yes, but if they're approached for that one additional component, maybe they say no at that time. So they had to agree that certain aspects may or may not get done. And that was just it worked for that unit. So just wanted to share that.
Thank you. That sounds like very interesting and maybe something I should bring back to some of the PIs here.
We tried. I don't know if you know Nina, but we stole Nina from CHOP and
Yeah.
yeah. So yeah, for someone like CHOP or a larger unit where you're doing a lot of co-enrollment, it was definitely, and actually the IRB, this was way back when, the IRB kind of came to us and said, you have too many, we had like 34 active protocols or something crazy. And they were like, look, this would be a way to kind of clean up your message. And it made Epic reporting a lot easier, right? Because then we would enter that, the common protocol, and then all the physicians would know whether or not they were enrolled, in research. So, because only certain people could see psychiatry. So,
yeah. So with that, like with the common protocol approach that you would do, it would just be that one approach, that consent. And so then once the patient became eligible for however many studies it was, you would just start implementing the studies.
Yeah. So then they would have to be approached. They would have to have another consent signed for that particular study. Like say your study also had an EEG, for instance. Mm-hmm. Then once they went through the common protocol component, which we usually did in one day, like it didn't, we had to tailor the department so that the investigators didn't feel like they were losing out on what may be left on their study, right?
Mhm.
So yeah, so once they went through those common elements, then they could be approached to do whatever else is left for any other particular study that they're eligible for.
Okay.
So that's, yeah. And it
Would
helped with
that
blood. We got a lot more blood that way as well, you know.
would that also increase like the enrollment window for some of those studies? Because maybe blood was like the first thing that needed to be collected, but maybe like an
Yep.
image.
Yep. And that certainly creates your priority list, right? So
Yeah.
for sure. Yeah. You know, and sometimes you're approached that same day, right? So yeah, all that has to be factored in, you know.
Does anyone else have anything they'd like to share? All right. Josie, I think we're all finished here. Thank you for recording and monitoring the chat for me. And then everyone who's still on the call, we're gonna post this recording on our website. I'll also share out the link once we compile everything together along with the slides. Thank you everyone for joining me today.